possibly go wrong by switching off women's ovarian function for decades? People didn't really understand about the hormones or the menstrual cycle. I mean, there was so little known about any of this. There's a lot of wishful thinking involved. It's like, this will be fine. But now we're finding that things are going wrong.
Dr. Lara Briden on the podcast. She is an ND, a naturopathic doctor, and best-selling author of Period Repair Manual and the Hormone Repair Manual. With more than 25 years of clinical experience, she is an internationally recognized expert on women's hormones, menstrual health, and perimenopause. If you are taking hormonal birth control, is that completely stopping ovulation?
Pretty much. It depends on the type of hormonal birth controls.
You say that ovulation is a vital sign of female health.
If ovulation is an indicator of general health, then lack of ovulation is an indication that something is wrong. It is possible and actually reasonably common to be having bleeds and not actually be ovulating. That's also an indication that something's not right. Often if you can fix one thing, like a key thing, it'll reverberate through the whole complex web. Your body wants to be healthy. It wants to do this. And if it's not doing it, it's because it has an obstacle, like something's preventing it from doing what it wants to do. So like first step would be.
Today, I am so excited to have Dr. Lara Briden on the podcast. She is an ND, a naturopathic doctor, and best-selling author of Period Repair Manual and the Hormone Repair Manual. With more than 25 years of clinical experience, she is an internationally recognized expert on women's hormones, menstrual health, and perimenopause. Her work focuses on evidence-based natural treatments for conditions like PCOS, endometriosis, and irregular or missing periods. Dr. Briden lectures globally on women's health, sees patients in New Zealand and Australia, and is a leading voice in reframing ovulation and menopause as vital markers of long-term health and longevity. Welcome to the podcast.
Yeah, thanks for having me. Looking forward
Absolutely.
to chatting.
Yeah, well, I mean, my audience is primarily all women, so they're going to be so excited for this podcast. I want to just get right into it. So you say that ovulation is a vital sign of female health. Can you talk to us a little bit about that?
Yeah, there's a great quote from my colleague, Professor Geraldine Pryor. I always drop her name because she's so amazing, and I feel like everyone should know about her. She's a Canadian scientist and clinician, and she describes ovulation as both an indicator and a creator of good health. So there's a lot going on there. It's an indicator in that it's our natural barometer to check in how we're doing. So during our reproductive years, if we're healthy, we should be ovulating approximately monthly. Of course, it doesn't have to be every 28 days, but it should fall within, some parameters, which we can discuss. And if that's happening, that's a really excellent sign that everything is going well, being fully nourished, not too much inflammation, just nervous system, everything's lining up to make that happen. And whenever, as a clinician, through the years, I would occasionally have a male patient, I would just reach that moment in the interview where I'm asking about periods and just think, wait, what? I don't have, I don't have the period to ask you. In my first book, I call the period the monthly report card. It's a very handy barometer, not just the regularity of ovulation, but how the period is. And then Professor Pryor's second part of the statement, that ovulation is an indicator and a creator of good health. By that, she means regular ovulation is how women make hormones. And the fact that this is not just sung from the rooftops, is sort of just is so puzzling to me because, of course, men love their hormones. Testosterone's amazing. It's great. And they are always talking about how to, optimize it. And for women, the way we optimize our hormones, estradiol and progesterone, which are also great, is we have a natural monthly menstrual cycle. And yet somehow, as through the era, I call it the epoch or the era of contraceptive medication, which is only about 60 or 70 years old. We've been locked in this paradigm where the view is that ovulation is optional and we can, just not do it. Switch it off with hormonal birth control, which is obviously, distressing to me as both a former scientist and a clinician. And so that's a lot of my work is about that.
Yeah. Well, this is a great topic to stay on. So if you are taking, hormonal birth control, is that completely stopping ovulation? Do we lose all of those hormonal cascades and changes there?
Pretty much. It depends on the type of hormonal birth control. So right at the start, I'll say the hormonal IUD is a little different, and we can maybe circle back to that because it's becoming more
Yeah.
popular.
Mm-hmm.
And I've always said, there's pros and cons to any method, but I've always said at least one redeeming factor of the hormonal IUD is it lets you have ovulatory menstrual cycles and make your own hormones, at least some of the time. It depends on the woman, and it depends on the particular IUD and how much progestin it contains.
Mm-hmm.
But all other types pretty much flatline hormones. So just to illustrate, like to really, I find this is a good way for people to understand. So on the combined estrogen methods, which would be this classic pill, the kind of pill where you have like 3 weeks of estrogen pill and then a week of placebo sugar pills, and it induces a bleed, which is like supposedly a period, but it's not a menstrual cycle. It's just a drug-induced bleed. There's no reason to do that monthly. You could have that drug-induced bleed any sort of timing. So the combined pill, the patch, the NuvaRing, all of those are, they pretty much flatline both estradiol, our main ovarian estrogen, and progesterone. And so case in point, if you were to do a blood test for those hormones, a serum test, while women are on those methods, which I've occasionally seen doctors do, and I'm just like scratching, like, what are they looking for? Those hormones will come back at menopausal levels, of course, because the ovaries are suppressed; they're temporarily shut down, and in the place of those two main hormones, estradiol and progesterone, which are so great. I mean, I'm a cheerleader for those hormones. In their place, there are these other molecules, medications, a synthetic estrogen, and then one of several different progestins, which do not, just categorically, do not have the same benefits as our own hormones. Like just full stop, do not, especially the progestins. They're very, very different from progesterone. And that's possibly why, and when this all started, 70 years ago, people didn't really understand about the hormones or the menstrual cycle. I mean, there was so little known about any of this. There's a lot of wishful thinking involved. It's like, this will be fine. What can go wrong? What could possibly go wrong by switching off women's ovarian function for decades? But now we're finding that things are going wrong. And I mean, we're starting to see that, the way science works, you start to see signals in the science of concerning things. There's almost no study that can definitively say something one way or the other, but there's been these signals coming out that it affects contraceptive medication, affects mood, which is really no surprise. There's been, quite a number of studies now that women on contraceptive medication have altered brain structures compared to women who cycle naturally, and things around bone health. And there's even sort of been one study on longevity, because I know longevity is your jam.
Yeah.
So, there is we can share it in the show notes. It was a few years ago now. It's a British medical journal. They had to do a big sort of zoomed out perspective or cohort study, tracking women, through the years. And they just had sort of 3 questions, like, are they on contraceptive medication? Are they cycling at all, or are they cycling regularly? And they found that women who are naturally cycling regularly had a reduced risk of early mortality. So they were, living longer. I mean, it's only now we can start to get data like that, because like I said, this whole experiment on women it's only really been a few generations. So we can finally start to see the data coming out. And yeah, I mean, once the penny drops and you really start to think about, wait, what have we been doing with women's hormones? It's it's obviously, for me, I'm very passionate about it. It's concerning. I mean, we're so micromanaging all other aspects of health. And then there's this like really major aspect of health that is, sort of been overlooked to some extent.
Absolutely. Can you just go through, so let's say the hormones are flatlined while you're on birth control. Can you go through some of the main benefits of estrogen and progesterone natural?
Let's do it. You might have had some of this. Have you had guests talk about some of the benefits before?
Mostly, I haven't really gotten into super deep, and I'm super excited to do that in this episode, is women that are still menstruating. So I've had a couple of like HRT experts, and, we talked a little bit about hormone replacement therapy, but not obviously as much, when you're cycling. So I think, it's becoming much more known in general. I feel like on the internet that birth control might not be the best option. So yeah, I want to lay out all the reasons, why.
Yeah. Well, let's actually start with that. Because as you know, perimenopause is having a moment. Let's put it mildly. Like it's like, what? So, I mean, I have my second book, Hormone Repair Manual, is my perimenopause book. And that came out in 2021, not even that long ago. And at that time, I didn't even put perimenopause in the title because no one had really heard of perimenopause. So I'm like, okay, I need to communicate this is for women in their 40s. And I was part of the awareness raising campaign. Like, you can be perimenopause happens while you're still having periods. And I would just venture to say the narrative has kind of gotten away from everybody. It's veered a little bit off the rails. There's a lot of just generally kind of hyperbole and kind of fear mongering going on around perimenopause. I'll just start with that. I just say it's okay. Like, some women don't have any symptoms with perimenopause, to be fair. Like some women sail through it. So that's just as a precursor. But the segue for me, based on your question, is that because of the awareness of perimenopause, we're having lots of discussion about estradiol and progesterone to some extent. Progesterone is like the Cinderella hormone, the kind of forgotten sister hormone. But there's been a lot of talk about the benefits of estradiol, our main ovarian estrogen, and in the context of, we need to replace it, which is valid to some extent. I mean, I'm generally supportive of estrogen therapy for especially the later phases of perimenopause where estrogen actually is low, pointing out estrogen is actually higher than normal in the early phases of perimenopause. But through all of this discussion, all of this like, estradiol is so great, I find it very jarring because I'm like, why? Wait, what? Like, why at 45 do women suddenly desperately need estradiol, but throughout their 20s and teens, 20s and 30s, it's fine to switch it off with hormonal birth control, and those women essentially don't have their own estradiol. So, I mean, you can see from my perspective, I'm like, okay, women, we actually need it when we're young, as much or more, arguably, because that's when we're building metabolic reserve and building bone density. And like, just to circle back, like we do have some data now that when teens are put on combined oral contraceptives, the combined estrogen method, and actually any methods to some extent, of birth control, hormonal birth control, they fail to achieve peak bone density in their kind of early 20s, which is really concerning. Like that's in terms of metabolic reserve, like a lot around aging. I'm sure you've had guests talk about this. A lot around the aging trajectory is set up like in childhood and in our teen years, like building metabolic reserve, building bone density, epigenetics to a large extent, sort of at that. So we really do need to, be thinking about young women and what, helping them now so they can have a better perimenopause in 20 years. And I know young people don't think that way. And so of course I always frame it to them as like, it's good for you now. You're having your own ovarian hormones, making your hormones is good for you now. So that brings us back to your question. What are the benefits of estradiol and progesterone? Estradiol is an amazing hormone. Like it is, the mitochondria love it. There's a few papers just about the really close, intimate relationship between mitochondria and estradiol. They love it, and they also make it. And to be fair, all humans make estradiol. So men need it. Children need it. I mean, obviously, in our women's reproductive years, we have a larger amount of ovarian estradiol. That's quite obviously different from men and children, but it's a very dynamic hormone. It's helps to regulate the immune system. It improves insulin sensitivity, largely by its sort of impact on mitochondria. It's anabolic, so it helps to build bone and muscle. Hence the, shutting it down with birth control seems to have not great impacts on bone. And so that's estradiol. In my first book, I call it Queen Estrogen. And then its companion progesterone, which I'm kind of more, if I'm famous at all, I'm probably more famous for, championing progesterone. It's, like I said, progesterone is the Cinderella hormone. It's largely been just pushed aside and thought, well, you really only need it for pregnancy or you need some analog of it to protect the uterine lining to prevent too much uterine thickening of the uterine lining. That's pretty much like from a conventional perspective, that's been the full extent of it. And yet progesterone has any tissue that has estrogen receptors has progesterone receptors. So they're counterbalancing. My colleague, Professor Pryor, has a beautiful paper about how they work in tandem, they work together. And which is actually a paradigm shift, which is sad because I mean, that's been there in biology all along. It's just scientists failed to kind of notice it. And I have an article called How Science Got It Wrong about progesterone. Part of the problem, I'll just tell you from a history perspective, there's so much that can be gleaned from the history of medicine. Part of the problem was that back in the 30s and 40s when hormones were being discovered, both estrogen and progesterone could be taken orally pretty early on. And they were body identical formulations of both of those hormones pretty early on. So the actual hormones. Progesterone could not. It can be taken orally now, but back in the day, it just wasn't practical to use it clinically. So it kind of got, so then they shifted, okay, well, let's make a progestin, which is kind of like progesterone, but really not. And then that got used and that got mistakenly called progesterone through all these decades even by scientists, which is incorrect because something else to your listeners, because I know I'm guessing you have kind of a sciencey group.
Yes.
Yes. Okay. So here's something to contemplate. Estrogen is a generic term that describes various estrogens, including estradiol, our main ovarian estrogen, including ethinylestradiol in hormonal birth control, including, xenoestrogens and estriol. Like there's just many, many different estrogens. And estrogen is a legitimate term for all of those. Progesterone is not a generic term. It's a chemical, like the clues in the name, urone, like it ends in it's a biochemical name. It's a particular hormone that the ovaries make, the placenta makes. We can also now, we can take body identical or bioidentical progesterone. But back in the day, you couldn't. And so that it just really didn't get studied. It got left out of the picture. And now we're learning that progesterone also is important for bone health. It's important for heart health. Here's a couple really key things about progesterone. Progesterone is probably protective for breast tissue, whereas all progestins, every progestin, slightly increases the risk of breast cancer. Real progesterone probably reduces the risk. I mean, this is where like the devil's in the details. Like that's kind of an important detail, and I feel like that illustrates a lot of else that's going on with that hormone. And the other thing about progesterone is that it metabolizes in the body to a neurosteroid called allopregnanolone. Has that come onto your radar at all? It's a very beneficial like hormonal neurotransmitter for the brain. It's so beneficial for the brain that it's actually being researched and used for traumatic brain injury, like in both sexes.
Interesting.
Yeah, and we're clearly meant to have it, and yet we've been routinely switching it off. Like the more I talk, even as the years go by, I was passionate about this 20 years ago. And now I'm just like, I really can't understand what has been happening. Like why such an important hormone has just been pushed aside. But I mean, that's progesterone in a nutshell. And yeah, the only way we can make progesterone is to ovulate or be pregnant. And we can take it.
Yeah. Well, thank you for that. I think it's important just to set the foundation of the benefits. Okay. So let's get into if you're in menstruating years. So it seems to me that so many women are having some sort of dysregulation in cycles that could be, and we'll break it down in a second, between like PCOS or maybe what is the term for missing a cycle due to stress?
Well, there's hypothalamic amenorrhea is one of the terms. Yep. Yeah.
So let's say you're a woman and you're starting to have dysregulated cycles, or you start missing, a cycle. What would you say to do? What like testing can you potentially do? What do you bring to your doctor? Because, I've had women tell me before that they went a whole year without having a cycle and they weren't really thinking about that much. So I would love to just put this on the radar of different reasons it could be, what to start exploring.
Yeah. I mean, as you can imagine, it's quite a big topic. So just to kind of circle back to what I said at the beginning, regular ovulation is an indicator of general health. So, and the only way to have a period, like a proper period, is to ovulate. Okay, I just wanted to clarify something else that maybe a lot of people don't know. I think this is part of body literacy, part of kind of understanding how the female body works. And I'll just say that, the female physiology has this reputation for being kind of complicated. And one of my mission statements is to demystify it, because through my lens, female physiology is completely logical. Before becoming a naturopathic doctor, I did work as an evolutionary biologist, and I published a paper. I went back, recently had a chance to go back and read my paper from like 32 years ago or something on sex differences in foraging behavior in animals. And I was like, wow, I was lit up and excited about female physiology back then. And this sort of reframing female physiology as the standard normal version of of human physiology, and male physiology as the quirky variant. Like in many ways, males are a quirky variant. They do have some weird things going. They, like, for example, men, quirky, make their hormones every day, whereas, women are cyclic and we make ours in a monthly, pattern. So for me, that's the normal. But back to your question of, if your period has gone missing, what is going on? Well, this is where the troubleshooting starts. And so, which totally makes sense, right? Like if ovulation is an indicator of general health, then lack of ovulation is an indication that something is wrong. Now, the other point I want to make is it is possible and actually reasonably common to be having bleeds, even somewhat regular bleeds, and not actually be ovulating. So these are called anovulatory cycles. This is actually really good for people, women, everyone, to have on their radar, because that's also an indication that something's not right. So just seeing the bleed doesn't mean everything's okay. And the way to track ovulation, the simplest way, is body temperature. And I'm sure people in your community are doing this. I mean, it's one of the most obvious metrics, biomarkers to track. And going back, 15 years ago, I'm just thinking back to when, I'm trying to remember, I should have got the details of this, but when when the first wearables came out and the first tracking, and they're tracking all kinds of stuff, heart rate variability, all this stuff, and they weren't tracking temperatures for ovulation. They had nothing about the menstrual cycle in those apps. And I'm wow. What? And so it was kind of a big, at the time, it was sort of this big, wait, what? This is one of the most obvious things in the world to track. So,
I track mine with the Oura Ring, and then Natural Cycles has a nice integration.
Perfect. A lot of people do that. So that's exactly what I'm talking about. So then in your case, perfect. That not only that you're having a period, but that you're ovulating. Mm-hmm. So if that's not happening, no ovulation or completely no periods, then we have to start thinking about, the way I frame it is, what is the obstacle or obstacles to ovulation in your case? So, there are many. So first step would be, I think you start to be concerned if it's been 3 months. So if it's you're just missing the occasional period here and there, most people know is pretty common. There can be a lag time. So if you had a really stressful time, you might find 2 or 3 months later, your period is timing is weird, or you miss one, or so that can usually be, if you think about it, that can be explained. That was something stressful, or I changed diet, because undereating is a surefire way to lose a period. But again, not immediately. There'll be a lag time. Yeah.
Can we talk about the lag time? Because I find that interesting. So how long is it typically? So people can go back and think, well, maybe I did this. Yeah. How many months ago?
2 to 4 months. Okay. So it's because of, I talk about it in my first book, Period Repair Manual. It's because of the 100 days to ovulation. So the follicles get on this little, it's not like everything's all happening flash in 1 month. There's this bit of buildup. The follicles are being recruited, and the ovarian follicles, the eggs, are being recruited and developed. And so, a disruption. It's not even especially with hypothalamic amenorrhea, losing your ovulation or a stall in ovulation due to stress or undereating to be clear, that is not a malfunction. That is a perfectly, your body, I mean, this makes sense to you, right? Like the brain, the executive control center, the hypothalamus has gone, it's got its inputs coming in. It's like something is wrong. It doesn't know what it is. Like it doesn't know that you're trying to be healthier with a diet change, but it's like, I don't, I'm not sure what's going on here. Like we're not going to risk pregnancy. And that's true even if you don't want a pregnancy, because it's just, that's how the body works. And in terms of the lag time, it's typically 2 to 4 months. So women will be like, change their diet, something quite restrictive. And it's like, oh, this is great. They have like a honeymoon period of 2 or 3 months. And then it's like, oh, wait, my period. Well, first I had an anovulatory cycle, and now my period's, my cycle's longer. Oh, now it's completely gone. And then likewise, there'll be a lag time coming back in. So then, and I've been through this with many, many patients. Like, so then you just like commit to eating more, eating enough, potentially eating more carbohydrates in some cases. And then it's not immediate. Like you can't just do that for 2 weeks and get a period. Like that might require a 6-month commitment at that point to get your period back. It really depends. So much depends on like the individual. So there's a concept called ovarian set point, which I talk about in my first book, that it depends on genetics. It depends on age of the woman. So how kind of mature the menstrual cycle is, and not just age, but how many years of actual cycling she's got under her belt. Because if she was on the pill for years, then her gynecological age is still young. As in, like, there's this maturation process that happens in the communication between the brain and the ovaries, where the brain starts to learn and figure out, what we can do here. So some women are a lot more sensitive to disruption than others. And just genetically too. I think women with, one way to think about it is like, it's going to depend on what all the epigenetics, all the years of, ancestry, like, did they live through famine? Like, were they the really tough type of ancestors who could live through famines? Were they, and I would say in the case of, if you come from a long line of agrarian ancestors or grain eating people, I think that my experience is then those are the individuals, especially when they're young, who probably need some amount of carbohydrate to be able to ovulate. And so that's been again, 15 years ago, that was kind of a controversial issue to say, but to talk about, but, I'm not anti, I'm all for, like, I'm supportive of low carb diets in certain settings for sure, because there's a whole other aspect of what's going on, which is the insulin resistance, which, on the other side of things, insulin resistance is also a way to lose a period. So back to the troubleshooting, after 3 months of consistent pattern of no periods, then the doctor needs to rule out some big things, like is there high prolactin? Is there a thyroid issue? Is there celiac disease? Like, these are all these are all reasons to lose a period. Is there some kind of other serious illness going on? And then sort of beyond that, beyond ruling out some of the big things, or early menopause. All my patients are always panicked about early menopause when they lose their period in their 20s, and which understandably, that's a very scary thing. That's premature ovarian insufficiency really only affects about 1 in 100, so it's unlikely. You do see it though, and the test, just to reassure everyone, it's very easy for the doctor to rule that out. That is a test called FSH. That can be done, so you can be reassured that it's not that. And then beyond that, then you move into trying to differentiate usually between hypothalamic amenorrhea and polycystic ovary syndrome, which are very different things physiologically in terms of etiology or what's driving them. But, and this is one of my takeaways too, so I'm always grateful to get an opportunity to share this with an audience. The diagnostic procedure of ultrasound for detecting polycystic ovaries is led to a lot of confusion because, and I'll just say this as simply as I can, the finding of polycystic ovaries, well, first of all, they're not cysts. I mean, there is such thing as ovarian cysts. That's a totally different thing. They're underdeveloped follicles or eggs. And that finding is super common, like super common. All women will have that finding at some point, just randomly. And the ovaries are changing all the time in terms of the size and number of follicles they have. Like they're constantly, like, it's a very dynamic system. So depending on when you kind of catch someone, you might see polycystic ovaries, PCOS cannot be diagnosed or ruled out by an ultrasound finding. But, and the reason I'm bringing it up, very commonly, women with hypothalamic amenorrhea who've lost their period to undereating can have polycystic ovaries on an ultrasound. And so the clinical guidelines, they're not supposed to give the PCOS diagnosis at that point, because part of the guidelines for PCOS is to rule out other things. So that, there should have been this step of like making sure it's not undereating, but often that step doesn't happen. And just imagine this, so I've seen them personally. Every clinician I've talked to has seen women who were told they have PCOS when they actually have undereating. And imagine the scenario where, because as soon as you hear you have PCOS, you go online or onto AI or something, and you're like, what do I do? What do I do? And it's like, oh, it's like you eat less and you maybe reduce your carbohydrates and you exercise more. And this might be an individual who that's how she's lost her period. So then she's literally, like I've said to so many patients, you are actually going 180 degrees in the wrong direction. Like you're walking down the path farther and farther away from ever seeing a period by restricting your diet more. Fortunately, it's all fixable. It's all reversible. Losing your period to kind of stress or undereating carbs, for example, is, it's just to say it hasn't harmed the female reproductive system. It's not it's a functional situation. So it's completely reversible. I mean, the harm it does though, is you've had those 6 months or 12 months of no hormones. Yeah. Back to what I said before, like ovulation is how you make hormones. So that is harming bone health and metabolic reserve. And that is why currently the gold standard for treatment of losing your period to undereating is to eat more. But alongside that, in more severe cases, the gold standard now is hormone therapy, like body identical estrogen and progesterone therapy, just as an interim measure until you can get your ovulations back. And it used to be the pill. And actually, another close colleague of mine who you could have on your radar is Nikki Key out of the UK. She was the one who spearheaded in the UK. She brought in, she campaigned to have proper body identical hormone therapy as the treatment rather than the pill, because the pill actually just makes it worse in lots of ways. So that's a long-winded answer to what do you do if you're missing a period.
No, I think that was super helpful. To stay on the PCOS topic, I've heard you say that there are 4 different types of PCOS.
Yeah. Let's talk about PCOS. It's funny that 4 types of PCOS. I actually coined that concept as sort of functional types of PCOS back in 15 years ago. I noticed that it's been embraced, which is great. Like it's really widely out there. So through my lens at the time as a clinician and on my blog back in the 2010 kind of thing, I just realized PCOS this is true for any syndrome, right? As soon as it's like just this is true for a lot of things actually, but as soon as you've got a diagnosis, in air quotes, that's really just a description of symptoms and not an underlying physiological process, you're going to have people falling under that diagnostic umbrella with all different ways they got there. Does that make sense, right? Like you're just like, what are you treating? Like you have to try to treat the underlying issues. So that's where, so the 4 types, basically by definition, I would say the simplest definition for polycystic ovary syndrome or PCOS, it's about to have a name change, which will be great, is that it's going to be good. The situation of high androgens or high excess testosterone in women, when all other explanations for that have been ruled out. I think that's the simplest way to think about it. And there are different drivers of excess testosterone in women. I mean, some of it's genetic, some of it's epigenetic for sure. Some of it's in utero exposure. So some women are just born with like a dialed up testosterone. It's a very challenging situation for them. It used to be a superpower. Comes from the genetics of the survivors, those women who could still have babies even when they're half starved half the time. That would have been a really good thing. But when that crashed into the modern food supply, it's become quite bad. And actually, because of epigenetics and in utero, the PCOS is amplifying. It's accelerating every generation. It's becoming more and more common.
And why do you think that is exactly?
Well, it's too, yeah. And I'll answer that, and then I will circle back to the 4 types. But
Yeah.
well, 2 things. So this is what the literature shows, what the science suggests. And again, it's a signal coming out of the science that a big driver of androgen excess in a female is being exposed to androgens in utero. So you can imagine it actually increases her risk of androgen excess by 5 times, which is a huge finding in science. Like anything that's 5 times higher is so. If you think about it, like if you've got women kind of running at high testosterone, and then they're pregnant, and the female fetus is exposed to high testosterone, she's going to be that much more likely to have PCOS. So this is accelerating it. Also, especially the insulin-resistant type of PCOS, which is the majority, is really closely tied to insulin resistance and metabolic syndrome. And as you know, that is accelerating. And so I have 3 books. So my 3rd book is Metabolism Repair for Women. It's all about insulin resistance. I'll just say insulin resistance it's the hidden epidemic. It's the epidemic just flying under the radar. A lot of people are noticing it, but it's unfortunately, I had a chance to give a talk to a group of the public last week, and I asked, how many people have heard of insulin resistance, and it was like one hand in a room of 50.
Oh, wow.
So people just really do not know about it. The really savvy health types do. Actually, what I've found is that it's kind of a sad situation because the people, the really kind of athletic, nutrition savvy, people know about it and don't have it. I recently did an Instagram post about testing for insulin sensitivity, and most of the responses, the people who'd had the testing, they were given their, asking me what's this reading? What's this reading? I'm like, actually, you're fine. That's good insulin sensitivity, because they knew about it. So but meanwhile, there's the people out there that the doctor's like, oh, you got high cholesterol, you got fatty liver, take a statin. And it's like, what? They have insulin resistance, and no one's. So, it's again, I'm pretty passionate about it. I feel like, and the way that insulin resistance is accelerating again is epigenetics. So it's the modern food supply, it's the environmental toxins. It's pushing the whole population down a very dark timeline into insulin resistance. I'm sure you had other guests talk about it.
Yeah. Well, I want to go back to PCOS, but really quick while we're on the topic of insulin resistance. So what lab markers are you typically looking at to, diagnose insulin resistance?
Great question. And I just wrote a whole book on this. I have a whole chapter on assessment, which I'd stand by. I talk about the different pros and cons of testing, different ways of testing insulin and stuff, and the signs and symptoms. But at the end of the day, there's a couple really simple blood markers that are just available on any standard lab test that people have had just from their GP or family doctor. High fasting triglycerides is a red flag of, flashing light of insulin resistance. So greater than, I think 150 is the units used there, 1.7 in our units, metric units. And then low, so that combo of high fasting triglycerides, low HDL, and high ALT. So one of the liver markers, transaminase is ALT, and it's the paper I shared on social media last week was a paper showing, particularly in women, which is always very interesting, a high ALT to AST ratio predicts insulin resistance as well as the HOMA-IR index. So it's, the HOMA-IR is the ratio with fasting insulin and fasting glucose, which is kind of more of the gold standard clinical tests. There's tests they use for insulin resistance in the lab, which you can't access clinically. But yeah, so I'm just right. I'm all over, and in women, and again, in women's, it's quite sex specific. So in women, an ALT greater than 19, when other explanations for that have been ruled out, is pretty strong evidence of insulin resistance. Symptoms would include high blood pressure, skin tags, tendency to reactive hypoglycemia is quite a strong symptom of insulin resistance. Women in general actually tend to get a lot more low blood sugar compared to men. That's because of our autonomic nervous system, so the way it's calibrated. But I learned so much from my patients and from my followers. I shared something about insulin resistance about 6 months ago, and someone chimed into the comments, and she's like, "Oh, well, I know I don't have it." I'm like, "How?" It's like, "Okay," and she's like, "Because I get hypoglycemia a lot of the time. So therefore that rules out insulin." I'm like, no, in fact, reactive hypoglycemia is a symptom of insulin resistance. So the fact that the whole narrative has been so glucose centric for so long has created a lot of confusion. And actually I recently just, my latest peer reviewed paper, changing the paradigm from glucose centric to insulin centric for PCOS specifically, like looking at, like actually either measuring insulin or looking at some of the surrogate biomarkers for insulin resistance. Does that align with what other guests have said, or what would be your kind of like for testing insulin resistance?
Yeah. I mean, I personally, so I'm doing like thousands of biomarkers, every quarter. So I definitely look at HOMA-IR, definitely looking, separately insulin and glucose fasting. I mean, this is, for anyone listening, totally not necessary. I just like all the data. So I have more of an understanding. I also do like a mirror test every single morning. So not forever, but I've done it for specific months so I can see exactly what's going on. But I just 2 days ago, I took off my continuous glucose monitor to also see what's happening when I'm consuming food, right? Like what is the response to that? So I do all sorts of things. I'm interested in your take on leptin. I feel like this has been a marker that is now becoming more popular potentially for insulin resistance and metabolic health.
Okay. So, I mean, to be fair, I haven't used it a lot clinically lately. I found it sort of a dead end back in the day. But so the idea that, I mean, my understanding, so obviously there can be leptin resistance, similar to insulin resistance. So an elevated leptin level can indicate a metabolic issue. I have a short section about this in my metabolism book. A lot of the time, I think it's going to be downstream from insulin resistance, maybe secondary. That's how I'd frame it, but I could be wrong about that. I mean, I think... Yeah. I mean, the thing about metabolic health, even compared to like, female hormones, it's a big network. Like all these hormones interact and talk to each other. And,
well, I mean, I think I love that you provided biomarkers that people are already getting in a just standard conventional lab, because a lot of these, I don't know if you have them over in New Zealand, but I do a lot of Vibrant testing, like Vibrant Wellness. And the panels are very comprehensive, but it's great to know that there are also, a handful of markers that individuals just getting a regular conventional lab draw can look at and have an idea of where they're at.
Coincidence. I just did a webinar for them yesterday.
Great.
So people can, I did a whole thing on perimenopause for Vibrant yesterday, and I actually included some slides on insulin resistance testing. So people can, if they directly want to sort of go and look at what I had to say about that. But yes, fair enough. I mean, there's fortunately, insulin resistance is pretty easy to detect. But unfortunately, it's not being detected a lot of the time. So back to the four people. I don't know if people are on their like the edge of their seat for the 4 types of PCOS. It really is. I find it actually quite intriguing how that 4 types has gone so like really entered the sort of conversation everywhere, which is great. In some ways, I feel a little shy about it because I really just when I kind of formulated those, I really didn't expect it to kind of go beyond my blog and my patients and. But I put it in my book, and like my husband said, if you're going to put something in a book, you can't, it's going to potentially go out into the world. So, I guess the reason I'm saying that somewhat apologetically is it hasn't been scientifically validated. Like this was just my like functional medicine kind of thinking about it, and clinical observation as well. But I mean, the 4 types, the main type is insulin-resistant PCOS, and it's by far the most common. It's at least probably 70 to 80% of people with the PCOS diagnosis. I have a little flow chart. So first step is it really PCOS? And the first step would be, or is it hypothalamic amenorrhea? Like if there are no androgen signs, And if there's evidence of undereating, then just go out of the, it's not a type of PCOS, just like completely like go into the other room. But if there is, like by androgens, I mean like there'll be some degree facial hair, thickening around the waist. These are all testosterone symptoms. Skin breakouts for sure, acne, and irregular ovulation potentially. Although some women, depending on the type of PCOS, sometimes they can be ovulating. But insulin resistance PCOS is the big one. The way to determine that is test, like we've just talked about, like determine if there's insulin resistance. Is there a high ALT? Are there high fasting triglycerides? Because then you know what you've got. And then at that point, it's in my thinking, the flow chart is like once it's not, you can have multiple types in like sort of, but really like if there's insulin resistance, then that's the primary thing. Like that's the thing to treat. But if not, like then you're left with like 20 or 30% of women with legitimately with a falling under the PCOS diagnostic umbrella, but actually don't have insulin resistance. So then the next type I sort of formulated was the post-pill. It's very specific, actually. It would be women who never had a problem PCOS symptoms before they went on the pill, specifically went on a drospirenone pill, which is the progestin that's strongly anti-androgen. Cyproterone is the other progestin that's strongly anti-androgen, although you don't even use that in the US, so that'd be more relevant for other countries. Those anti-androgen progestins really suppress skin oils. Like they suppress androgens and they suppress skin oils. And then my observation is that stopping them. So then and again, there's a lag time. There'll be a 3-month honeymoon period. And then about 3 months after stopping those medications, there can be post-pill acne, like, women have never seen before. Like it's very distressing to talk to them because they'll just, it can be terrible acne. And they will, of course, blame themselves. It's like, oh, it's something I'm eating. I must be doing, like something's broken with me. I must be doing something wrong. It's like, it's not you, it's this medication you were given and now you're in a withdrawal syndrome from drospirenone, basically. So that's,
is that called spirolactone in the US?
They're very similar medications, actually. They're sister medications. They're different though. Drospirenone is the progestin version of spironolactone. Okay. Spironolactone actually in low dose can maybe be part of treatment for some types of PCOS. But yeah. So usually the story with post-pill PCOS, it's in a way it's not really true PCOS because they're not sort of genetically or even epigenetically in that category. They're just they're in a medication withdrawal situation that can last 2 years. So it's not an easy fix, but it would be a lot of it's like around, you're going to be okay. Like, I think you're going to be okay. You're just, and part of it will be maybe struggling to get their periods back or to get their periods after stopping the pill. And if you think about it, that's entirely logical. Like if you shut down ovarian function for years and then remove the drug that, like, you can't necessarily expect your whole brain and ovarian axis to just spring into action. Like, depending on the woman, that's going to require, it takes a while. Like, it takes a while. And we do have some studies on that. It can take up to 18 months to kind of get your ovulation going. Wow. One of the best markers, like when I'm working with patients, I always ask them, it's like the key for me in terms of predicting and understanding what might be going to happen with their body would be like, how many years of natural cycling did you get under your belt before it was all shut down with hormonal birth control? Because the more, the better. So Professor Geraldine Pryor, who I've mentioned a few times, she has it wasn't her paper, but she shared a paper with me years ago where they're able to demonstrate that it takes 12 years for a woman a girl and then a woman to fully mature her menstrual cycle. So 12 years to kind of go for, like, to get all calibrated, all happening between the brain and the ovaries, making robust levels of progesterone, having good, robust luteal phases, temperature rises. It doesn't mean, earlier in the 12 years, she's still having cycles, she's still ovulating, but like to fully kind of step into her full power hormonally, it could take 12 years. So if you think, when I talked to Professor Pryor about that, I actually heard her talk about it in an interview, and then I asked her about it. And I was like, but wait, what? But what if you then, shut it all down with hormonal birth control? She's like, well, you have to resume the maturation process after you stop. It's really quite sobering when you think about it in those terms. And also another point to make about the pill is that, when it was first invented back in the 60s or 50s, I guess, it was like, right, it was for women who've already had some babies and they just want to, time their children. So they're fully functioning, reproductive health. And then you shut it down for a few years and then they found, but when you stop the medication, periods start back up. Sure, for those women, but that's a very different scenario than giving it to a 12-year-old, which is what we're doing now. Like, we don't have any data on like what happens if you give if you shut down a 12-year-old's hormonal system and then remove the medications at 35 so she can have a baby. Like, what's going to happen? Like, she might ovulate, but she really might not for a long time. But anyway, that's post-pill. So we got insulin-resistant PCOS, post-pill PCOS, and then the other one I sort of characterized was inflammatory PCOS. You do get women who just, and again, this would be in my, framing of these types. It would be like, again, for the inflammatory PCOS, these would be women who don't have insulin resistance. I mean, you could also have, insulin resistance is inflammatory. It's a type of inflammation, but I'm talking about with these women, it's usually there's something like autoimmune going on. So anyone who works with women should always be on the radar for autoimmunity because we get it a lot more commonly than men. So I would test for thyroid anti-TPO antibodies, just looking for that, any kind of evidence chatter of autoimmunity. And then, in terms of mechanisms of what that's doing, it's just that in women, inflammation can increase testosterone to DHT conversion. So it's in some women, inflammation can be kind of androgen producing. So just to say again, androgens are there. As women, we definitely have a sweet spot. So androgens are great. We need a certain amount. Our ovaries make we make quite a lot of it actually, but beyond a threshold of androgens, they're not healthy.
What are you typically looking for? Like less than 70, less than 55? Where do you usually land on that?
Yeah, I would say, it's going to be the whole picture of looking at anytime you're assessing androgens in women too, you want to be looking at SHBG. Have you had people talk about sex hormone binding globulin?
A little bit, but not in this context.
Yeah, because for women, you can't really think about testosterone without, and also to be fair, the lab testing for testosterone in women is not very good because it's not calibrated for women because we have such low levels. We have like a 10th or a 20th of what men have. So the labs aren't really meant to be measuring very well down in that low end. I tend to look at SHBG because it's sex hormone binding globulin. Men generally don't want very much of it, but like women, it's actually really important for us. And it binds estrogen and testosterone. So it shelters us from androgens to a large extent. So you need your SHBG to be up in the mid range. And then that will be protecting us from too much androgens. Typically women with both androgen excess and insulin resistance lower SHBG. When I did my insulin resistance testing post last week, a doctor chimed in and said she relies on SHBG as one of the main markers for insulin resistance in women. I thought that's pretty interesting. So that in terms of how to assess androgens in women, it's symptoms more than anything, I would say. So facial hair, jawline acne, back acne, and the thickening around the waist, the kind of increased visceral fat. So you know that visceral fat is also called android fat. Like it's in women, like androgens will promote that weight gain around the middle quite noticeably, even in someone with a normal BMI. So even with someone who's quite slender, but if she's kind of got that thickened waist, that'll sort of correlate with androgens. Right. So insulin-resistant PCOS, post-pill, inflammatory. And then the fourth type is completely different, really. Like it's actually just an entirely different situation. It's because all the other three types have mainly ovarian androgens, like the ovaries is a source of androgen excess, plus the low SHBG, plus the inflammation. But fourth type is adrenal PCOS, and for them, their adrenal glands are the main source of excess androgens. They typically will they often won't have insulin resistance because DHEA does not promote insulin resistance the way testosterone does in women. And they'll often be ovulating and having cycles. They'll be having regular cycles, but all these androgen symptoms. And if you measure, you'll see that their androstenedione, and testosterone and SHBG are all normal, and their DHEAS is elevated for their age. This is the other thing about androgens. Sorry, the other thing about testing, especially DHEA, it's age specific. So the reference ranges really have to be stratified for age, which they often aren't. I'll have to always just kind of go back and kind of check on my, check with AI about like sort of what is the appropriate DHEAS level for, 35-year-old woman versus a 20-year-old woman. So, and then with androgen PCOS, with adrenal PCOS, it's more about regulating, actually boosting cortisol, which I know cortisol is like the baddie, but the conventional treatment for any kind of adrenal androgen situation in women is, including something called adrenal hyperplasia, is the conventional treatment would be low dose hydrocortisone. And there's you can use licorice, or there's some, natural ways to do that too. Vitamin B5 or pantothenic acid can help to regulate adrenal steroids. So that's sort of those are the 4 types.
Well, thank you for an overview. I know we're going to be coming up on our time soon, but would love, if we just focus on that primary form of PCOS that you mentioned, the insulin resistance. So if, a woman, has received labs, she has insulin resistance, what would be the first few steps that you would start taking to remedy that?
Yeah. Well, like I said, I wrote a whole book on this, metabolism repair for women, because my experience clinically is sort of stating the obvious, but there's no one size fits all treatment, right? Like if it were that simple, then I think, we wouldn't have potentially the epidemic that we have happening now. I think, but if I was going to, so in the book, again, I talk about metabolic obstacles. So when I was talking earlier about periods, I talk about obstacles to ovulation. This would be obstacles to like, what is your body not getting? Like, why has it gone down this path of not functioning at that level, at the cellular level, really, the chronically elevated insulin? I mean, obviously diet is, without question, like our modern food supply is the culprit to a large extent, to a huge extent, environmental toxins, that combo. I mean, if you dig down, like why is that happening? I think it's a lot of it's to do with what it does to the microbiome, the terrible things that ultra refined carbohydrates do to the microbiome, the small intestinal bacterial overgrowth that they promote, the intestinal permeability, all that. Those are big drivers of insulin resistance. I'm in the camp, I'm curious where you are actually with this, but I'm in the camp where high dose omega-6 is, I think, probably driving insulin resistance to some extent, at least in some people. Where do you land on that? I'm actually just curious about the whole vegetable oil, seed oil debate.
Yeah. I mean, so I don't consume seed oils. I mean,
right.
It's such a hot topic, right, on the internet. I used to post about it more like years ago, but now I'm kind of, I'm just letting everyone else take over that one. I mean, it's interesting because the data supposedly says that, it doesn't have a high impact and it's okay. But for me, it just doesn't. If you just watch a simple video of how like canola oils are made and like how processed and refined they are, I just completely stay away from them. And I've also, I can't say it's because of only that. I obviously am implementing exercise and high quality sleep, and my diet is really dialed in. But personally, I just avoid them. And I haven't ever had any metabolic issues. So
I'm sure you're very metabolically healthy. I think, and again, it's interesting, what I was saying earlier, like you're testing your insulin, which is fine. Like it's good to kind of get that data. But the people who really need to test their insulin are not. But anyway, just back to omega-6. I mean, obviously, yes, as you say, it's super controversial. I am not a lipid expert by any means, but I'll just say from a biological perspective, the high ratio of omega-6 to omega-3 potentially does weird things to the mitochondria. Also, it interacts with the endocannabinoid system in not a good way, that potentially increases appetite in not a healthy way. So, it's through my little spidey senses, like my former, my biologist lens, I'm like, every time I see, one more sort of paper come around of potential hazards of high dose omega-6, I'm like, this is not good. All that said, the complexity and the nuance is that, of course, linoleic acid, omega-6, is also an essential nutrient. So it's both, right? Like it's not a poison, like we're meant to have it. Anyway, so that's part of it. So back to your question of what do I recommend? I talk my readers through, or like the same approach I take with my patients. Pick some easy wins. I mean, pick some things that are sort of not yet doing that you can really make you feel better, start to move the needle, rather than aspiring to, locking in the perfect diet and exercise, because I just feel like it doesn't work, especially for people who are really far down the path of insulin resistance. Because one of the main features of insulin resistance, this is the takeaway, they're locked into carb burning. They cannot access their own body fat for energy. So they are exhausted, hypoglycemic. These are the people who would need like a muesli bar just to kind of get through, a walk or through the afternoon, to kind of instruct them to, intermittent fast, or like it's really hard. So I guess the way I would see it is take magnesium. So my husband was joking. He's like, on my headstone will be the little epitaph of like, if in doubt, take magnesium, because it's really helpful. It improves insulin sensitivity. It helps people sleep, just get feeling a bit better. So I pair it with taurine, really interesting anti-aging nutrient that improves insulin sensitivity, supports mitochondria. So all my patients take magnesium and taurine powder. We have these beautiful powders in Australia and New Zealand that combine those. Glycine maybe in there, like just some insulin sensitizing nutrition, get that into them. And then that'd be sort of first step. Second step is cook at home. And one of my metabolic obstacles, because I know it from my patients, some people just don't cook, or they don't have the time, or they just don't feel like they have the knowledge, or they're very intimidated by it. So I had a whole section in my book about like the easiest possible like whole food dinners you can make. Like I asked my followers, like, what are your like one dish, just meat and veg, like as simple as you can do it. It doesn't have to be complicated, because it's non-negotiable, because the next step is sheltering from the modern food supply. And that I use that term sheltering because that's what it's like. Like we are bombarded everywhere you go, like on the plane, any store, any hotel, like you literally have to sort of protect yourself from just this onslaught of garbage food that is driving. And the only way you can do that logically is to have something else to eat. Like you can't expect people to not eat, to avoid ultra processed food if they don't have nothing else to eat. So, those are kind of the first steps. And then there's lots you can do around circadian rhythm. And then there's, I would also just say, give a plug for fixing the gut. So this, of course, I'm a naturopathic doctor, so everything comes back to the gut. But, the degree to which problems in the gut are driving insulin resistance is actually probably mind-boggling. Like not just the intestinal permeability, but there was just a study that Nick Norwitz, I don't know if you follow him, he just shared it. I'll mention his name because that's how I found out about the study, but that statins dramatically reduce GLP-1 hormone, which is a gut hormone, via their impact on gut microbes and the bile salts and the bile acids. So I'm like, yet another, every couple of weeks, there's some study about how problems in the gut are driving metabolic dysfunction. So 2 of the 10 patient stories in my book are about fixing the gut. So if there's small intestinal bacterial overgrowth, that I say to my patients, nothing's going to work until we sort that. Like you can restrict calories to your dying, and like until you get the the SIBO sorted out, your metabolism's just not going to sort of be functioning. That would be my clinical read on it. And not everyone has gut problems, so this is why it's troubleshooting, right? Like some people's guts are fine, which is great for them, but and then there's for women, there's thyroid, there's autoimmunity, there's food sensitivities, it's not complicated. It's more just about, again, troubleshooting, like finding the aspect of health that, is the one that you need to fix in your case.
Yeah. Yeah. So personal. I totally get that, but also a huge fan. I owned a medical clinic and we had functional medicine providers all from IFM. And I got to learn so much about the gut, and it was just wild how many things would improve in the patients at the clinic with fixing their gut,
So just to give you a really concrete example, I know we have to finish up soon, but I put this patient story in the book. I had a patient who, like classic story, she really craved sugar. She'd been beating herself up. She's like, oh, I'm such a bad person. Like, I need to have better willpower. She put all these, tried to like not have the, sweet slice in the afternoon, and taking supplements and fixing her sleep and like going lower carb and all these things. And finally we detected she had some like significant issues going on with her gut. She had blastocystis, which is it's a parasite that doesn't affect everyone, but doesn't bother everyone, but some people who have it have problems. She had a lot of bloating and discomfort. Mm-hmm. So we treated that. I said, well, let's just forget about the sugar cravings. Let's just like treat your gut. You've got this bloating, treated the gut. And then 2 months later, she's like, my sugar cravings are completely gone. Wow. After years of, trying to micromanage that, it's like, rather than micromanaging, actually, this is what can happen with health. It's so dynamic. Like often if you can fix one thing, like a key thing, it'll reverberate through the whole complex web and result in, reduced symptoms and sort of better functioning. This is my, I think my biologist lens coming through, mm-hmm. and also just all the years with patients, just being like, your body wants to be healthy. It wants to do this. Yeah. And if it's not doing it, it's because it has an obstacle, like something's preventing it from doing what it wants to do. So if you can it's easier said than done, to be fair. I'm not saying I can always with precision find the exact thing that people need, but when you do, it affects every system. It affects periods, it affects metabolism, affects mood. There's a gut-brain axis, which is like just astonishing, actually, the degree to which the communication between those two systems happens. So.
Well, this has been an amazing episode. I feel like we really got to hit on some things that I've been wanting to cover, and it's just such a pleasure. Thank you for all of your work. I am very well aware you're like, an OG in this space. And I just love it. You've been thinking about it for so long and working with mm-hmm. women for so long. So thank you for everything that you've done. We'll make sure to include your website and your social media and everything in the show notes. And also, we'll include links to the book, and anything I can do around the books, just let me know.
Well, and thanks. It was great to meet you. So I enjoyed the conversation.
Absolutely. Well, maybe we'll see each other at an event sometime. Vibrant is having their event here in Austin, Texas, actually, in just a month or so. So maybe we'll get to meet in person soon. But thank you so much for coming on the podcast.
All right. Take care.
All right. Have a great day.